Chapter 20, Vascular Physiology, Screencast 3. The topic of this screencast will be an introduction to blood pressure. Now, blood pressure, keep in mind, is a hydrostatic force because once again we're looking at the force blood that is exerting against the vessel wall, so pressure is exerted, but also we have to talk about the contractile force of the heart itself. Now, when we're talking about a blood pressure gradient, that is going to be the exchange in pressure from one end of the vessel to the other, and that's going to be the driving force. As we've addressed already, pressure is highest in arteries, so we consider them to be pressure reservoirs, and lowest in veins, so those would be volume reservoirs. Now, when we talk about blood pressure, typically we're talking about arterial blood pressure. And one of the things to keep in mind here, the blood flow in arteries pulses with the cardiac cycle. Systolic pressure, that is the arterial pressure when the ventricles are contract or a state of systole, and really it's the highest pressure generated in arteries, so they're stretched. Recorded as the upper number of the blood pressure ratio, example, systolic blood pressure is 120 millimeters if blood pressure is 120/80. Diastolic blood pressure is the pressure in the arteries as the ventricles relax or during diastole. This is when we see the lowest pressure generated in arteries. This is the recoil phase. And this will be recorded as the lower number of the blood pressure ratio. Example, previously if blood pressure is 120/80, the diastolic blood pressure will be 80 millimeters of mercury. Pulse pressure, this is the other thing that you'll have to be calculating. And this is the pressure in arteries that's added by contraction of the heart. And how you calculate pulse pressure is the difference between systolic and diastolic blood pressure. So here, we're looking at a pulse pressure of 40 if blood pressure is 120/80. And what this number actually means, it's the elasticity and recoil of arteries. And as we get older, this tends to decline, and also with disease. Pulse pressure, it's what allows for palpation of a throbbing pulse in elastic and muscular arteries. Remember, the blood flow to arteries is pulsatile in nature. Here, this is a really important figure that I want to spend some time with. And I've talked about this before. Remember when we talk about on the arterial side, pressure is our friend, and on the venous side, pressure is our enemy. So let's kind of take a look what the overall driving force here is. Okay, so this value here is mean arterial pressure, and I'll talk about that in just a second. And that is the pressure across the entire cardiac cycle. And here in this situation, it's about 93 millimeters of mercury. Notice it's not the mathematical average of systolic and diastolic, and we'll actually talk about why that's the case. But look what the pressure is by the time we get back to the atria after the vena cava is drained there. It's 0. So basically, if we want to calculate the driving force, it's going to be what is the pressure at the beginning of the tube, and we subtract the pressure at the end of the tube. So now, because the pressure at the end of the tube is 0, we have an overall driving force of 93 millimeters of mercury across the entire vascular system. Now, imagine what would happen if it wasn't 0, if it was 10. So now we have 93 minus 10, and we now have a driving force of 83 millimeters of mercury, and basically we've lost 10. So hopefully you can see why pressure on the venous side is not desirable at all. Now, one of the things to keep in mind here, the previous diagram showed us mean arterial pressure, and as we indicated, it's the average arterial blood pressure across the entire cardiac cycle. This is not something that you will have to calculate. This is something we will calculate in lab, but is not something that you're responsible for calculating on the next unit exam. Now, note, when we talk about mean arterial pressure, it is not the mathematical average of systolic and diastolic pressures. That's what we think of when we hear average. But because the heart spends more time in a state of relaxation or diastole, it has to be weighted more. So typically, we expect diastolic pressure to be closer to diastolic overall. Here, we've been using 120/80 as an example of blood pressure. So mean arterial pressure, if we were to calculate it, would be 80 plus 40 divided by 3, and that's going to give us 93. Now, one thing that we can get from mean arterial pressure is an index of perfusion. Once we have a mean arterial pressure less than 60, we're now looking at a situation where there might be insufficient blood flow. Now, when we talk about capillary blood pressure, pressure is no longer fluctuating between systolic and diastolic. And we've talked about this previously. So when we talk about blood flow through capillaries and veins, it's going to be constant. So it's not rhythmic at all as it is in the arteries. Now, we've talked about this before. So this pressure has to be high enough to result in exchange of substances, but it also has to be low enough so we're not damaging vessels. Remember, capillaries are not very large vessels. So generally at the arterial end of the capillary, we have a pressure of about 40 millimeters of mercury. At the end or venous end of the capillary, it's going to be under 20 millimeters of mercury. And so basically, we talked about this previously, and these are the overall driving forces that are responsible for filtration at the arterial end and reabsorption at the venous end. Now, one concern that I do want to address is cerebral edema. And this is when there starts to be an excess of interstitial fluid in the brain. This is something that can occur if we have extremely high mean arterial pressures, something on the border on the lines of 160 millimeters of mercury. So now we're going to have excess filtration, and that results in this excess interstitial fluid. And the real issue here is there's nowhere for this pressure to dissipate because the brain is enclosed in the skull. Now, what we have to keep in mind now here is venous pressure. And we talked about venous return previously in the last chapter. And remember, venous return is responsible for ventricular filling, and that's an important thing to keep in mind. So once again, when we talk about venous pressure, it's going to be low. And once again, it's not pulsatile. It's going to be constant. Now, when we look at the blood pressure gradient here, we're looking at a blood pressure of about 20 millimeters of mercury in the venules and pretty much 0 in the vena cavas. So now we have a problem. How are we going to have venous return in a low pressure system? So this is something that's important. We have to kind of go back and look at the anatomy of veins. So here we actually have valves. So what we have here that aids in maintaining or insisting venous return is the skeletal muscle pump. So this is going to help make sure that we get venous return from the limbs, especially the lower limbs. And what's happening here as skeletal muscle contracts, the vessels that are within the muscle, the veins, are going to be squeezed. Now, blood is going to be pushed upward, and kind of imagine a tube of toothpaste. You squeeze that, the toothpaste moves upward, and then we start to see there's no backflow because of the valves. Now, another factor that's going to aid in venous return is the respiratory pump. This is going to help bring blood back up into the thoracic cavity. So during inspiration and expiration, there's going to be a pressure gradient. And basically, this pressure gradient helps pull blood up into the thoracic cavity. So we refer to that as the respiratory pump. Now, if we look at some clinical situations that can be problematic, we've talked about this before as far as deep vein thrombosis or DVT. So what we have now is a clot or a thrombus in the vein. Typically, the most common site for DVT to occur is within the calf muscles. If we look at risk factors for DVTs, it could be heart disease, but especially immobility. So one thing that we know, it's important to not sit all day, to be mobile, and so on. Things that might be an indicator are fever, tenderness, redness. You might also have pain and swelling in the areas that are being drained, and a rapid heartbeat. Now, the real concern here potentially is a pulmonary embolism. And this is the most serious of all consequences or issues associated with a deep vein thrombosis. So now we have a clot that's breaking free and it lodges itself or gets stuck in the pulmonary artery. This in turn can cause respiratory failure and death. If we look at varicose veins, now we're talking about veins that are dilated and they have lots of twists and turns. the valves all of a sudden are non-functional because of this twisting, and we now start to see a pooling of blood. Generally, these are most common in the superficial veins of the lower extremity. Things that may contribute to this are going to be genetics, aging, a lot of time standing, obesity, and pregnancy. If you happen to have these veins in the anal rectal region, now we're actually talking about hemorrhoids, and those tend to be due to increased abdominal pressure during defecation. Now, when we talk about blood pressure, we now have to keep in mind we're looking at that gradient. And so previously we looked at mean blood pressure in the arteries, or at the beginning of the circuit, is 93 millimeters of mercury. By the time the blood from the vena cavas drain into the heart, we now have zeros. That's giving us our net driving force of 93 millimeters of mercury, and that really is the driving force. Now, if we increase the gradient, that increases the driving force, so we will have a greater flow. So one thing to keep in mind here is the difference is going to be increased by cardiac output. Now, if we look at another clinical situation that's very significant, it's circulatory shock. Now, the issue here is we don't have enough blood flow to perfuse tissues. This can be due to a number of reasons. It could be due to an impaired heart. There could be a problem with low venous return. Some examples of things that can result in circulatory shock are a bleed or hemorrhage, dehydration, allergic reaction. We could look at an obstructed vein. It could be venous pooling. That's a result of prolonged immobility. There could be extensive vasodilation for a number of reasons. It could be bacterial toxins. Also, there could be some problem to the brainstem in which we seem to lose vasomotor tone.